Hello, my name is David Myung. I'm here to talk to you about our experience with autonomous AI for the detection of diabetic retinopathy in the US. I have no relevant financial disclosures related to this technology or presentation. I'd like to acknowledge the many amazing colleagues that I work with at Stanford, including my colleagues in the retina division, those in the primary care, population health, internal medicine, and endocrinology departments, a research team, as well as Stanford Diabetes Research Center for funding. What is diabetic retinopathy? It's the manifestation of high blood glucose in the microvasculature of our retina that can lead to characteristic changes such as bleeding, swelling, leakage, as well as scarring that can lead to reduced vision and blindness. Mainstays of our treatment for this are laser therapy, specifically pan-retinal photocoagulation, as well as intravitreal anti-VEGF injections. While these are effective, these are also things that we like our patients to avoid if possible through preventive measures. Diabetic retinopathy is truly an epidemic. It's the #1 cause of blindness in working age adults. It's preventable, and yet too many patients go blind from DR every year. Too many patients develop not only diabetes, but go on to develop DR. And the only way really we have to stave off this tidal wave of change are annual diabetic eye exams. Unfortunately, many health systems report less than optimal adherence numbers. And so key ways for us to prevent this is blood glucose and blood pressure control with the help of our primary healthcare colleagues, as well as early detection and treatment of eye disease. In the primary healthcare setting, HEDIS measures are a key driver. HEDIS stands for the Healthcare Effectiveness Data Information Set. These are a list of things that every patient with diabetes needs to have done with the help of their PCP. And one of those things is a retinal exam. Unfortunately, there are many barriers for our patients for getting these exams. And so we felt that by partnering with our primary care colleagues, we could help improve adherence with this requirement through remote screening and telemedicine. We felt an ideal solution would be able to identify disease requiring in-person attention or reducing physician and medical assistant and other resource utilization while also increasing throughput. Eventually, we found that AI could potentially address all these issues, especially because in July 2020, AI exams were included in the HEDIS measures, and in January 2021, a CPT code specific for autonomous AI went into effect. We started by creating a telemedicine networking workflow, starting with 1 and increasing the number of sites up to 5 with our remote telemedicine network, and then up to 7 with our AI workflow. Initially, we started with photos taken in the primary healthcare setting when patients come in to see their PCP, those who needed to get their retinas taken through a non-mydriatic camera. Those images are read by our retina specialist, led by Dr. Ted Lang and Dr. Veena Mahajan in our department. And then those deemed needing to need a in-person referral were given that, and others were told to return in a year for another photograph. We then layered on top of that an autonomous AI workflow using IDXDR by Digital Diagnostics. This was cleared by the FDA in 2018. And what it does is it takes the images, reads them, and makes a determination whether it's negative for more than mild diabetic retinopathy or positive for more than mild retinopathy. And those who are positive for more than mild diabetic retinopathy are then referred for an inpatient, in-person exam with our one of our ophthalmologists retina colleagues. The way it works is an algorithm that detects biomarkers such as hemorrhages, microaneurysms, exudates, and so forth, and it makes an assessment and clinical decision whether the patient needs to be referred. We at Stanford have an excellent and amazing IT and technology and digital solutions team that help integrate IDX into Epic. So now when a primary care physician orders this test, the result comes out much like a blood test. They can go to the results tab, pull up not only the image, not only the result, but also the image, as you can see here. Here are some images of us showing during our launch of the various cameras, such as at Santa Clara and Los Gatos, showing the NW400 camera that's used in conjunction with IDX. We now have 7 total sites throughout the Bay Area, extending down south as far as Los Gatos and Santa Clara, out east to Hayward and Pleasanton and Emeryville. Here is a chart just showing a bird's eye view of how the remote care model has improved care. So the y-axis is just the percent of patients who are getting their required annual diabetic eye exams. And then over time, we see that there's an increase in that percentage of patients exceeding our 90th percentile goal, as you can see in the red line. Even in the midst of COVID, we see an uptick of these screenings. And then as we transition to AI, we see yet another uptick as we see that AI is further improving resource utilization and throughput. Word on reimbursement. So the codes have changed a little bit. So 92227 used to be the diabetic the retina screening code. Now it's the parent code to 92228, which is where physicians or a qualified healthcare professional interpret photos and prepare a report. 92229 is the one specific for remote imaging via point of care automated analysis or autonomous AI using technology such as IDXDR. In conclusion, remote diabetic retinopathy screening is a robust care model. We found that even in the face of the COVID pandemic, we had improvements in our ability to deliver care and get patients the diabetic eye disease screening they needed. Partnering with primary care, healthcare, and endocrinology offices helps to widen that reach. It's really a collaborative effort that needs to be done in order to get to our patients. We found that autonomous AI testing was extremely useful for streamlining workflow for both primary care and eye care providers. It has certain advantages that a human-based system can provide, in particular, getting the results on the day of the visit. EHRs can help monitor eye exam outcomes, quality metrics, and referral patterns that I showed you before. It can be a powerful tool to continue to help improve the quality of care. I want to acknowledge once again the many collaborators I have on this project, funding from the Stanford Diabetes Research Center, as well as my many colleagues in our retina division who make this possible and seeing our patients who are referred in from our primary healthcare sites. Thank you so much for your attention.